Hi everyone, welcome back to another day of our review session. We are on day 67 out of the 90 days. And for those who are already in the classroom, welcome back to our session. Thank you for being with us. And for the newcomers, the newbies, we are inviting you to also stay with us all throughout the session. And we are also inviting you to enroll into our NCLEX program. So kindly visit our website at www.stancoast-nclexcoaching.com, where you will be able to access those materials that we are offering. We have about 200 hours of on-demand videos and also 20 hours of animated video series, plus the 3,000 NCLEX-style questions and 200 NGN test questions. So this is something that you can access throughout the 6-month period with your subscription. Now, don't forget to hit the like and subscribe button, and also share this video with your friends who are also preparing for the NCLEX. And today we'll be talking about the different test items on the fluids and electrolytes. This is part 2, and let's go right ahead. So the first question is this one. A 44-year-old patient has been admitted with acute kidney injury due to dehydration and presents with oliguria, anemia, and high potassium levels. What is the nurse's immediate priority? Is it A, insert a Foley catheter to monitor urine output? Or is it B, attach the patient to a cardiac monitor? C, administer epoetin alpha to treat anemia? Or D, administer sodium polystyrene sulfonate to lower potassium? Hello, Mary. Hello, Joan. So what is your answer here? A case of a patient having AKI due to the dehydration, now manifesting the oliguria, anemia, and high potassium levels. What would be your answer here? So while waiting for your responses, let me have letter A. Option A, insert a Foley catheter to monitor urine output. This is incorrect. We know that intake and output monitoring is very important, but we are being asked about immediate priority, especially in a patient with high potassium levels, with oliguria, anemia. So I really want you to recall the contributory factors, especially the cardiac function. Think about the electrolyte imbalances that could cause life-threatening cardiac dysrhythmias. Hello, Abdul. Hi, Dipali, Ahmed. Welcome, and AJ. We also have Bobby. All right, guys. Letter A is incorrect, as we know it doesn't really address the immediate risk associated with hyperkalemia. Important though, this is important. However, it doesn't address the pressing issue, especially with the high potassium levels. What about letter B? Attach the patient to a cardiac monitor. This is the correct answer. We know that when a patient will have high potassium levels, it can cause cardiac dysrhythmias, even severe ones. And this could be life-threatening. So it's very important that we can identify those life-threatening cardiac arrhythmias, so we will be able to treat them accordingly. All right, so we will be able to capture those dangerous heart rhythm changes, and this is our priority action. All right, once you're gonna capture those life-threatening cardiac dysrhythmias, then of course you're gonna have to implement those nursing actions that could probably lessen those cardiac dysrhythmias, maybe the administration of the antiarrhythmic medications, or if not, if there's no preceding orders yet, then we gotta notify the medical provider about that one. What about letter C? Administer epoetin alpha to treat anemia. This is a medication that can stimulate the bone marrow to produce red blood cells, right? It is a synthetic form of erythropoietin. This is going to treat the anemia. However, it is not going to treat the life-threatening condition. The epoetin will work over a period of weeks. This can take several weeks to even start to increase the red blood cell production. Again, it is not going to treat the immediate concern. Letter D, administer sodium polystyrene sulfonate to lower potassium. Hi, Janet. Hello, boss babe. If you answered letter D, administering polystyrene sulfonate kyaxylate, this is a drug that can cause exchange of the sodium and also potassium ions in the gut. But this will not take effect right away. It has an onset action of 2 to 12 hours. Onset is about 2 to 12 hours. It will not treat the hyperkalemia instantaneously. Okay. And the duration of action, as soon as that medication will be within that therapeutic range, it can act about 4 to 6 hours. So take note about the onset and the duration of action. All right. Our patient needs immediate assessment to make sure that we will be able to capture those life-threatening cardiac dysrhythmias. That's the first step in this scenario. Okay. We need to detect these life-threatening dysrhythmias so that we can manage them accordingly. All right. The other interventions are also important. However, they are not going to address the immediate issue. So our correct answer here, it is letter B. Now let's move forward to our next item. A patient with small cell lung cancer is experiencing SIADH, or the syndrome of inappropriate antidiuretic hormone secretion. Which of the following findings should the nurse report to the healthcare provider? Is it A, hematocrit level of 42%, B, sodium level of 120 milliequivalents per liter, C, weight gain of 2.2 pounds or 1 kilogram, or D, urine output of 280 mLs over the past 8 hours? Your patient has SIADH caused by the small cell lung cancer. So which of the following options here you should report to the medical provider? If you had answered letter A, hematocrit level of 42%, this is within the normal range. Within the normal range. Nothing to worry about 42% hematocrit. This is going to tell us the concentration of the red blood cells in relationship to the plasma, which is the solvent, right? It is not an immediate issue. It isn't even a problem. Let's have letter B. Sodium level of 120 milliequivalents per liter. What do you think about that? We know that the sodium level supposedly be at 135 to 145 milliequivalents. That is the normal range. So our patient's value is way low. And this is going to cause so many problems, especially neurological function. Okay? The patient here can experience confusion. They can also develop seizures, even coma, if not addressed promptly. So take note about the neurological manifestation, confusion, seizures, and coma. Take note, guys, about sodium. It is a very important electrolyte, especially in the neurological function. If it is so low, again, take note of these. These are the manifestations that you should be worried about, especially with this low of the sodium. So this is the correct answer. Why is there hyponatremia in SIADH? Why there is hyponatremia? The reason for that is because when the patient has syndrome of inappropriate antidiuretic hormone, they will have excess production excess release of the antidiuretic hormone. And when this happens, the antidiuretic hormone will cause massive reabsorption of fluids that are in the kidney tubules. Those fluids are supposed to be excreted by the kidneys. However, this condition is there is an excess of antidiuretic hormone. So this will reabsorb most of the fluids back into the circulation, causing dilutional hyponatremia. There is way too much fluids circulating in the body, in the bloodstream. So your sodium level here will drop significantly, not just 130, but it will drop significantly to even a severe level. And this is our main concern here, especially with the SIADH. If your patient has letter C, weight gain of 2.2 pounds or 1 kilogram, yeah, that is actually a sign of retention, right? And 2.2 is expected, but this is not a critical manifestation compared to 120 milliequivalents of sodium. This is less critical. If you answered letter D, urine output of 280 mLs over the past 8 hours, this is expected in a patient with SIADH. And the reason for that, it's because of the massive reabsorption of water in the kidney tubules. It goes back into the circulation, and this is not really a critical finding in such case. This is expected compared to the 120, which is going to cause severe neurological issues. Again, our concern here is the brain function, confusion, seizures, coma. If we are not going to treat the hyponatremia, this can be irreversible, can cause irreversible brain damage. So our correct answer here, it is letter B. Alrighty, let's have number 3. A patient with hypovolemia and multiple draining wounds is admitted. Which method will give the most accurate assessment of the patient's fluid balance? Is it A, assess skin turgor, B, measure daily weight, C, monitor urine output, D, check for edema? So take your pick here, guys. Your patient has hypovolemia with multiple draining wounds. What assessment you should perform to accurately detect their fluid balance? Is it assessing the skin turgor? Is it B, measure daily weight? Or is it C, monitor urine output? Or D, check for edema? If you answered letter A, assess skin turgor, we know that this is important, right? When we are evaluating our patient for fluid volume or fluid status. But assessing the skin turgor is a less reliable indicator of fluid balance, especially in older adults. Less reliable. And when we are dealing with elderly people, remember that their skin elasticity is going to be much decreased, right? Elasticity is decreased in elderly. Even if our situation did not really mention about the age of the patient, but then again, in general population, if we are going to use the skin turgor assessment, this is not going to be the most reliable testing. Decreased in elderly. Alrighty, what about letter D? Check for edema. Will this be the accurate assessment? We know that edema is basically the shifting of fluids, right, from the intravascular compartment into the interstitial space, but it will not accurately reflect overall fluid balance. Okay? Edema. That's basically the shifting of the fluids from the intravascular compartment into the interstitial compartment. That's the edema. But again, it is only going to reflect accumulation of fluid in the interstitial compartment. It is not going to give us an idea of how well the patient is perfused in the vascular compartment. If you had answered letter C, monitor urine output. I know this is important. Urinary output will give us a better idea how the kidneys are perfused, right? We know that. The hourly range in the adult is around 30 to about 60 mLs per hour. But it does not account for other fluid losses or gains, especially insensible fluid loss, especially when the patient is draining wounds from these areas. So the urinary output will not give us accurate measurement because of the scenario. The patient has draining wounds. And then again, there's also that insensible fluid loss through evaporation. When the patient talks, that's part of it. Evaporation coming from the skin. And so urinary output is also an important nursing action, actually, but it is not as accurate compared to measuring the daily weight. This is important, guys. The daily weight is going to capture a much accurate measurement. It will also measure the fluid balance and also reflecting the changes in the total body water. So if there will be even small weight changes in the body weight, it can indicate significant fluid shifting. And this is going to be very crucial for us in managing the patient's hypovolemia. So take note, guys, we are going to use letter B, which is measuring their daily weights. All right. The others are also important, but are less accurate compared to letter B. Now let's have number 4. A patient is prescribed spironolactone or aldactone, an aldosterone antagonist. Which statement by the patient suggests that they understand the medication instructions? Is it A, I need to drink at least 8 glasses of water daily? B, I should use a salt substitute to reduce sodium? C, I will eat more foods that are high in potassium? D, I will have apple juice instead of orange juice for breakfast. So your patient is taking spironolactone. So you are going to identify that statement that they understood the teaching regarding this medication. Statement that reflects understanding about the use of the spironolactone. Will you choose A? If you had answered letter A, I need to drink at least 8 glasses of water daily. This is an incorrect statement because increasing the fluid intake is not necessary when the patient is taking spironolactone, and may not be advisable as well because of the fluid retention that may occur when they do this. And if you had answered letter B, I should use a salt substitute to reduce sodium. And recall, guys, when you are going to encounter this product, salt substitute, this is rich in potassium, right? And this patient that is using spironolactone, which is a potassium-sparing diuretic, this is a medication, a diuretic, that will be used for those patients that may have had adverse reactions from the other diuretics, such as Lasix, wherein they're losing way too much potassium, right? And so potassium-sparing diuretic will be used for this type of patients. However, with the long-term use of the potassium-sparing diuretic, what can happen is that they will start retaining the potassium. They will gain some more potassium in their system. And so when we are going to teach this patient, we should tell them to avoid using the salt substitute because they are rich in potassium. All right, this doesn't reflect understanding. If you had answered letter C, I will eat more foods that are high in potassium. Why would they say that? The medication is already going to conserve the potassium. So why would they need to take in more potassium? This can also lead to hyperkalemia. So both items or both choices, B and C, can exacerbate hyperkalemia. Items B, or options B and C, not items, but options rather. So these are statements that should be corrected. Can cause hyper. Okay. So this is incorrect. So if you answered letter D, I will have apple juice instead of orange juice for breakfast. Now, this is more of a dietary modification, right? We know that orange juice has higher potassium content, whereas apple juice is not known to have high potassium content. And this is something that you should select in this question. Apple juice is lower in potassium compared to orange juice. So this will be a safer option for them when they are taking a diuretic such as potassium sparing, like aldactone or spironolactone. So this is a question on dietary modification. Apple juice is less in K, whereas orange juice is high in K. We don't want to cause hyperkalemia in this patient. So the correct answer here is letter D. Number 5, a patient with sudden confusion and low sodium levels is being admitted. How should the charge nurse allocate the patient's room? Is it A, place the patient in a shared room? B, assign the patient to a room close to the nurse's station? C, put the patient in a room near the water fountain? Or letter D, connect the patient to telemetry for T-wave monitoring? Your patient has hyponatremia, being admitted for that because of the confusion. Sudden confusion. So if you are the charge nurse in this unit, how are you going to put this patient? Are you going to put this patient in letter A, B, C, or D? Remember, guys, when your patient has sudden confusion caused by the low sodium, yeah, that is something that needs to be corrected. But then again, it will take a little bit time to, it will take time to correctly or safely correct the sodium imbalance. We are not going to rapidly correct that one. But in this scenario, regarding the patient's confusion, how will you promote safety? This is a safety question. Safety issue. If you answered letter A, place the patient in a shared room. Well, this is not a good idea. The confused patient may disturb other patients. And putting them in a semi-private or a shared room is less ideal. It doesn't really facilitate close monitoring, which is necessary for this patients with sudden confusion. So we are going to eliminate letter A. If you answered letter D, connect the patient to telemetry for T-wave monitoring, is that really essential? Letter D. We know that T-wave monitoring, monitoring the patient's cardiac function is important, but when we are looking for the T-wave, this is much more appropriate for those patients with hyperkalemia. So it doesn't really serve any purpose. The rationale here is not, or the reason why they're going to continuously monitor the patient with the telemetry is that they were doing it for the wrong reasons. Again, T-wave monitoring is most appropriate when the patient has hyperkalemia. It doesn't address the patient's confusion caused by the hyponatremia. So we are going to eliminate that. If we are going to put the patient in letter C near the water fountain, what do you think about that one? If they are going to be close to a water fountain, a water source, they probably will end up drinking from that water fountain, especially if they're going to be placed on water restriction. This can further cause dilution in their sodium. So we are not supposed to put them close to a water fountain. Okay? We don't want them to consume more water as they're going to be restricted in their water intake. Again, hyponatremia, if not treated, this can lead to cerebral edema, right? Yeah. This is something that we should be watchful for. Take note in their water intake as well. We don't have any other answer, which is to assign the patient to a room close to the nurse's station. The patient will require frequent monitoring and observation so that we could promptly intervene if their confusion worsens or if there are any other signs of hyponatremia complications. So letter B is our correct answer. Close observation is needed. Watch for complications. So think about those complications that I had mentioned earlier. Seizures. Right? Yeah. They can develop into seizures if not closely watch. All right, that's for number 5. Let's have number 6. A post-op patient with a perforated gastric ulcer has been on nasogastric suction for 3 days and now has a sodium level of 127 milliequivalents per liter. Which of the following orders should the nurse question? You're correct, Caleb. Also fall. Thank you, virtuous lady. Very good. A post-op patient with a perforated gastric ulcer has been on nasogastric suction for 3 days and now has a sodium level of 127 milliequivalents per liter. Which of the following orders should the nurse question? Is it A, administer 5% dextrose in water at 125 mL per hour, or B, infuse 3% saline at 50 mL per hour for a total of 200 mL, C, give IV morphine sulfate 4 milligrams every 2 hours, PRN, and letter D, administer IV metoclopramide or Reglan 10 milligrams every 6 hours, PRN for nausea. Your patient's sodium level is 127. You are going to question or verify that order. So which order would require verification or questioning? I see so many answers. B, B, D, B, A, B. Which one is correct here? You should question this order. So among the options here, which of these options should be questioned by the nurse? We know that our patient's sodium level is 127, hyponatremia. If you are going to administer 5% dextrose in water, D5 water, at 125 mL per hour, what does this IV fluid do? This is a medication, or this is an IV fluid that will turn into a hypotonic solution once the glucose is metabolized. Guys, please take note. Outside the body, this is an isotonic IV fluid. Outside the body. However, when it enters the body, this will turn into a hypotonic solution when the glucose is metabolized. When glucose is metabolized. Take note. Outside the body, D5 water is an isotonic solution. D5 water. But once it enters the body, when the glucose is broken down, and once it is metabolized, it is going to turn into a hypotonic solution. So this is an IV fluid that can worsen the patient's hyponatremia. It will further dilute their sodium level. It will cause a significant drop from 127. Okay? This IV fluid is a hypotonic once it is used up or once the glucose is already metabolized in the body. Be careful. This is only 5% glucose, but mostly containing not so much of the sodium, guys. This will cause further dilution. If you had answered letter B, yeah, this is actually one of the treatments that we will be expecting in a case of, it is one of the treatments in hyponatremia. Actually, this will be beneficial for the patient if they are not able to take in oral sodium tablets, then it will be used for the hyponatremia. Okay? Now, if we had answered letter C, give IV morphine sulfate 4 milligrams every 2 hours PRN. PRN, it did not say routine. And take note, guys, the patient here has a perforated gastric ulcer, has been on nasogastric tube suction for 3 days. It said give IV morphine sulfate 4 milligrams every 2 hours PRN. Only PRN, only as needed. This is indicated for this patient that has this condition, a post-op patient, right? They are going to require some pain management as well. So there's no doubt that we should disregard this nursing action. This is a good nursing action, supposedly. So we are eliminating that because we are looking for that option that is supposed to be questioned, right? So if you had answered letter D, administer IV Reglan 10 milligrams every 6 hours PRN for nausea. Yes, that's another good nursing action. As we know that with a post-op patient, they're going to have that nausea and vomiting as well. So we will not be picking this option as well. They will have the intermittent nausea and vomiting. So again, guys, take a look into that option that can worsen their hyponatremia. And that is no other than letter A, D5 water. It is a hypotonic solution once the glucose is metabolized. Although it is considered isotonic outside the body, but then when the glucose is used up, it will dilute further the patient's sodium. So correct answer here is letter A. Let's have number 7. But before we go to do this, number 7, I'm inviting you to enroll into our NCLEX course. So kindly visit our website at www.stancoast-nclexcoaching.com or click the description box below for the link. Question number 7. An elderly patient on iso-osmolar continuous tube feedings exhibits restlessness, agitation, and weakness. Which lab result requires immediate reporting to the healthcare provider? Your patient is receiving iso-osmolar continuous tube feedings, now exhibiting restlessness, agitation, and weakness. So which of the following lab results requires immediate notification to the doctor? Will that be A, potassium level of 3.4, calcium level of 7.8 milligrams per DL, sodium level of 154 milliequivalents per liter, or is it phosphate level of 4.8 milligrams per DL? Let's have letter A. We know that the potassium level is supposed to be at 3.5 to 5. Some of you guys are probably using the 5.2 as the upper limit, but for the sake of the NCLEX, usually they will use the 3.5 to 5.0. So we'll stick with that one. This is a mild hyperkalemia, it doesn't require immediate reporting. It doesn't. Letter B, calcium level of 7.8 milligrams per deciliter. Do you think that this is something that would call for an immediate notification? Not really. It will require follow-up, but it is not as urgent as letter C, which is the correct answer. Hypernatremia. The sodium level is supposed to be at 135 to 145 milliequivalent. So that's about 10 points above the upper limit, right? When your patient has this level of sodium, this can also lead to neurological manifestations. This is also going to make them very restless. They will be agitated. Okay? This complication also, that severe hypernatremia can also lead to seizures. Okay? There's going to be a risk for seizure in this patient with a severe hyponatremia. Dominique, what are the levels for calcium? For the calcium, okay, serum calcium level. That is around 8.6 to 10.5 milligrams per deciliter. In some books, they just put it as 8.5 to 10.5 for a much easier memorization. This is from Lippincott, 8.6 to 10.5. Be careful, guys, regarding the 9 to 10.5. Probably that comes from the Saunders or maybe Archer. No, it's not consistent with medicine books. I always use those values that are more consistent with medicine books. 9 is kind of like you're in the moderate range already in the normal value. So it's better safe to use the 8.6. Okay, so be careful with the other sources of information. I've already noticed that several times, and I don't know why they're doing that. Okay, so if you are answering letter D, phosphate level of 4.8 milligrams per deciliter, what is that? Is phosphate 4.8 within the range? We know that the phosphorus level is somewhere around a 2.8, or actually 2.5 rather. Let me erase that one. 2.5 to about 4.5. So your patient is somewhat higher than the normal, but hang on a second, 4.5. Yeah, so it's not that high yet about the phosphorus level. It doesn't really require immediate reporting to this patient. Okay? For this, yes. And so we are going to eliminate letter D. It will, letter C instead. The patient's sodium level, which is 154. Again, this is hypernatremia. Okay? That is therapeutic range. What do you mean by therapeutic range? Okay, I'm not quite sure with the therapeutic range, what you're pertaining to the therapeutic range, but we are talking about the serum level of the phosphorus here, which is 2.5 to 4.5. But then again, our patient's value is 0.3 higher. It doesn't really cause for an immediate concern compared to letter C. So our correct answer will be letter C, hypernatremia of 154. Okay. Number 8. Oh, let's go back to that real quick. Again, guys, think about the sodium. If there is such severe low or severe high levels in the sodium, what you're going to worry here is about neurological function. Both extremes can lead to neurological dysfunction, can lead to seizures. It can also lead to confusion, restlessness, agitation. So worry about those things. Okay. If the calcium is severely low, maybe about 7.2. If they have any manifestations such as stridor, I would also consider that. That could be a severe case of hypocalcemia, but it is not reflected in the scenario. So I'm not going to worry about that for now. Number 8, in preparing meals for a patient with kidney failure on a low phosphate diet, what should the nursing assistant ensure is removed from the tray? Is it A, skimmed milk, B, grape juice, C, mixed green salad, D, fried chicken breast? Again, in preparing meals for a patient with kidney failure on a low phosphate diet, what should the nursing assistant ensure is removed from the tray? Is it skim milk, B, grape juice, C, mixed green salad, D, fried chicken breast? So you're actually somewhat delegating this to the nursing assistant. What should the nursing assistant ensure is removed from the tray? So basically you're delegating them, telling them, hey, we are supposed to maintain a low phosphorus intake for this patient. If you answered the letter D, fried chicken breast, what do you think about this one? We know that it is not really the healthiest option because of its high fat content. High fat content. But it is not high in phosphorus. Not high in phosphorus compared to the other products. So we don't necessarily have to remove the chicken breast, fried chicken breast in their tray. If you had selected letter A instead, which is the skim milk, any kind of dairy products, it is a dairy product, and they are known to be high in phosphate. All righty. We are going to select letter A, skim milk. Dairy products are known to be high in phosphorus or phosphate, and they should be avoided in a patient's diet. And we know that with a patient that has renal failure, they will have trouble in excreting the phosphorus or phosphate. And this will accumulate in their system, and this will complicate into bone disease and other cardiovascular issues. If you had answered letter B, grape juice, it is not high in phosphate and doesn't need to be restricted in their diet. And if you had answered letter C, mixed green salad, the leafy green vegetables are actually low in phosphate and are typically, they are encouraged to take this kind of healthy diet. So we are eliminating grape juice, mixed green salad, and fried chicken breast. Take note, guys, dairy products are high in phosphorus. So this is the diet or the food item that we should restrict. Okay. All right, guys, let's have number 9. Why was a central line used for a patient receiving 25% dextrose parenteral nutrition? Is A, the infusion can be administered faster with a central line? Or is it B, the hypertonic solution is diluted more effectively through a central line? Or C, the risk of infection is lower with a central line for this infusion? And D, blood sugar tests are more accurate with central line samples. The question is about central line. Why are we supposed to use a central line receiving TPN with 25% dextrose? Is it A? Is it B, C, or D? What do you think, guys? Whoops, what happened to that? If you answered the letter A, the infusion can be administered faster with a central line. Oh boy. The word faster. Ooh, that's a red flag. We are not going to administer the infusion in a faster rate. They are not supposed to be given in that manner because rapid administration could cause complication. It can cause hyperglycemia in our patient. The purpose of having a central line is actually to prevent phlebitis. That is why when we are administering TPN, it should be given through a central line, not a peripheral IV access, because the TPN can lead to phlebitis, inflammation of the vein, and not recommended anymore. Even the PPN, it's not even recommended to have that because of the high incidence of the phlebitis. And this is not the reason that we are using a central line to give them in a faster rate. Oh, no. What about letter D? Blood sugar tests are more accurate with the central line samples. Are we supposed to obtain sugar testing through the central line? No. This should be obtained through peripheral samples, capillary samples, okay? Blood sugar tests are more accurate. Nope. It is not going to be the source of our blood sugar testing. It is not reliable when we are, even though if you're going to follow the protocol of, let's say, flushing the line, stopping the infusion, you're just disturbing the infusion. Before you're going to collect, there's some protocol in some hospitals where they're going to collect blood specimen through that central line, right? But particular for the blood glucose, it would not be efficient if we are using this route by collecting specimen for the blood glucose through a central line. We can do it through the peripheral blood sample, through capillary. So this is an inefficient method of checking the blood sugar. Such a hassle, guys. And the steps involved when you are collecting the specimen through the central line will be there will be lengthier and a little bit more complicated because you have to stop the infusion, you have to flush the line to make sure that you are not getting an adulterated specimen. And so again, inefficient method. What about letter C? The risk of infection is lower with the central line for this infusion. Lower. I don't know that. That is lower. No, that is incorrect. There is no such thing as lower risk of infection with the use of central line. They actually have a higher risk of infection compared to the peripheral lines because of the placement and also with the complexity of the care that we are supposed to do for this patient with this kind of IV access. Okay, they have a higher risk, not lower. So you don't have any other option here but letter B, which is hypertonic solution is diluted more effectively through a central line. Take note, our patient is taking a TPN. Guys, that would require dilution of the solution in order to prevent the damage to the veins. Okay, it requires dilution. That's why they're coming in big bags. All right, let's have number 10. Oh, we almost are through here. It's already 9:51. Number 10, for a pregnant woman with eclampsia receiving IV magnesium sulfate, which symptom should the nurse report immediately? Is it A, decreased breath sounds in both lung bases, B, no response in patellar and triceps reflex tests, C, sleeping most of the time, and D, feeling nauseated? Patient that is pregnant with eclampsia and now receiving IV magnesium sulfate. So which symptom should the nurse report immediately? Your patient is taking magnesium sulfate. Why? Or which symptom would require you to report this? Will that be decreased breath sounds in both lung bases? Okay. No response in patellar and triceps reflex test. I'm seeing letter A's, B's, letter C. Okay, let's rationalize. Let's have letter D first. With letter D, feeling nauseated. Nausea is a common side effect of magnesium sulfate, and it is not concerning, right? Nausea is a common side effect of magnesium sulfate. So it doesn't really require that immediate notification. So we can address that, but not as critical compared to the answer that we'll be selecting in a minute. If you answered letter C, sleeping most of the time, is this going to be that finding that you should report right away? Take note, guys, that magnesium can also result to the drowsiness. It can also lead to fatigue. Okay? These are your drowsiness in the context of sleeping most of the time, drowsiness, and also fatigue. These are expected side effects of the magnesium sulfate. But then again, if you're going to compare it to letter B, which is no response in patellar and triceps reflex test, this is the correct answer. Remember, when you are going to treat this eclamptic woman, your nursing responsibility here is to test for deep tendon reflexes. Okay? That is your nursing action in the treatment. When you are dealing with a patient with magnesium sulfate infusion, always do your deep tendon reflex checking. DTRs. If their reflexes would be 1 or 0, it said here, no response. This is actually reflecting magnesium toxicity, hyporeflexia. Hyporeflexia or no response, areflexia. This is actually causing magnesium toxicity, which can also lead to respiratory depression. Respiratory depression. And this will lead to cardiac arrest as well. There's way too much of the magnesium circulating in their body. Take note, guys. What I would recall whenever I encounter a test item that has magnesium, I will always think about that as a muscle relaxant. And it can also cause CNS depression. Think about that. It can relax those smooth muscles, the uterus. It can also be helpful in treating those patients that may have status asthmaticus. It can relax those smooth muscles. However, if they become toxic, if the level is way too high, I'm talking about the magnesium level, this can lead to these issues, respiratory depression and also CNS depression. Think about that. So if your patient has letter B, areflexia, that is an indicator that they are getting the toxic amounts of the magnesium. Letter C, sleeping most of the time. This is expected when they are getting the magnesium. It's not a sign of toxicity yet. Getting drowsy, that's one sign. But comparing it to letter B, yeah, this is deadlier. All right, so you're going to pick something that would pertain to CNS depression and also respiratory depression. All right. So that's it for number 10. Let's have a number 11. We are gradually getting an OB. Yeah, we are going to get there. Number 11. A malnourished patient has a calcium level of 7.9 milligrams per DL. What should the nurse do next? Is A, obtain an order to check ionized calcium level. Wouldn't CNS depression be low breath sounds? Not necessarily. When you have a low breath sounds, let's go back into that question once again. It said lung basis, decreased breath sounds in both lung bases. It didn't say decreased breath sounds on all lung fields. If you're going to associate CNS depression, it's not about the exchange of gases, but rather the concern here is basically hypostatic pneumonia. This is basically the need for them to have breathing, coughing exercises. It doesn't really reflect that there is CNS depression. When you're going to worry about respiratory depression, it's not about the lung sounds, but rather the rate of their breathing. They will become bradypneic, less than 12 cycles per minute. Okay? If you are thinking about CNS depression, respiratory depression, it's not about the breath sounds, but rather you're going to worry more about the rate of breathing. The rate, the amount of inhalation, expiration within a minute will be decreased in CNS depression. And if we are talking about lung basis decrease, it's not something that should be reported immediately, okay? It is not crucial. It is not as critical compared to letter B, all right? And I think you asked earlier, Dominic, about the treatment of the hypernatremia with that 156. What we're going to administer with that patient will be a gradual reduction of their sodium level. This will be the administration of D5 water, okay? And so this will slowly dilute their excess sodium in their bloodstream, all right? So that is one part of the treatment. Now, let's have number 11. Where are we at? Okay. A malnourished patient has a calcium level of 7.9 milligrams per DL. What should the nurse do next? Is it A, obtain an order to check ionized calcium level? B, administer oral calcium citrate? C, test the parathyroid hormone level? D, give vitamin D supplements? Your patient has malnutrition and their calcium level is 7.9. What should you do here? Will that be A, obtain an order to check for ionized calcium level? B, administer oral calcium citrate? C, test the parathyroid hormone level? Or D, give vitamin D supplements? The case is on a hypocalcemic patient. However, there is that additional description. They are malnourished. If you had answered letter D, give vitamin D supplements, you are already in the intervention or in the action phase, which basically is not addressing the need for investigation. Okay? Your patient has hypocalcemia, however, they are malnourished. So again, vitamin D, we know that the vitamin D is very important in the absorption of calcium. But what we need here first is basically to confirm the accuracy of the value by checking the ionized calcium level. This is the correct answer. Why? Why there is a need for us to obtain an ionized calcium level, especially in a patient that is malnourished? The reason that they have a low calcium level, it is because of the low albumin levels. We know that albumin is going to be low in a case of malnutrition, negative protein balance. Yeah. Your patient is malnourished. They have a 7.9 milligrams per DL calcium. So the 7.9 is not going to be really accurate for this patient because they are malnourished. Most of the calcium is going to be attached to the albumin levels, and of course they are expected to be low in their albumin because of the malnutrition. So when we are going to deal with this patient, it is very important to investigate further, get an order to check for the ionized calcium level, that calcium that is not attached to the albumin. It is not affected by the protein binding. So this is going to yield a more accurate reflection of their calcium level. Detects more accurate calcium level. So look for that ionized calcium level value compared to just a regular serum calcium level. If you answered letter C, test the parathyroid hormone level. Well, what about that? Letter C. We know that the parathyroid hormone can affect the calcium levels, but the immediate concern in this question is to verify the actual calcium status. Again, the patient has malnutrition. That is the defining factor in this scenario. The patient has malnutrition. They have low protein levels. Okay? They have low albumin. And so again, this will not, this alone will not give an accurate detection of their calcium in their body. We need the ionized calcium instead. If you answered letter B, administer oral calcium citrate, you're also in the intervention phase already. You're not doing your diligent investigation, but we really need to first confirm the real ionized calcium level in this patient first thing. Okay? So B, C, D are all incorrect. We need to have the ionized calcium level. And again, our case is on a malnourished patient. There is low albumin. Number 12, which patient should the nurse prioritize for assessment after shift change? Is it A, patient with a potassium level of 5.0 and stomach cramps? B, patient with a sodium level of 145 who wants water for a dry mouth? C, patient with a magnesium level of 1.1 milliequivalents per liter experiencing tremors and heightened reflexes? D, patient with a phosphorus level of 4.5 milligrams per DL and a calcium phosphate deposits and soft tissues? Which patient should the nurse prioritize for assessment after shift change? Is it A, B, C, or D? So test A is faster than C. It's not about the fast detection. What we actually want in that question is to confirm the real value of their calcium, to confirm really if that, especially with the case of malnutrition, that is the defining, as I've said, that is the defining factor. The patient's 7.9 value does not truly reflect the overall calcium concentration in their bloodstream because they are malnourished. We are supposed to confirm that by asking the doctor to order the ionized calcium. Okay? We are only going to test letter C if there is an involvement of the parathyroid hormone. Okay? It's not about the faster identification. No, We are wanting to verify really the accuracy of the value by checking their ionized calcium. So you're answering letter C, okay? Patient with a magnesium level of 1.1 milliequivalents, experiencing tremors and heightened reflexes. Number 12. Okay, let's have letter A. Patient with a potassium level of 5.0 within the normal range. Stomach cramping. Yeah, it's not life-threatening. You don't need to address this patient right away. Is there really a need for us to address this patient right there and then? No, there are more pressing issues comparing here. So let's not neglect this patient, but we will put this patient in a less priority section. Let's take a look in letter B. Patient with a sodium level of 145 milliequivalents who wants water for a dry mouth. 145. Patient has is having that sodium level in the upper limit, upper range. It doesn't really require acute condition. You are going to monitor this patient as well. You don't neglect, but keep monitoring. So if they are actually having that dry mouth, they are manifesting signs of mild dehydration, right? Mild dehydration doesn't require immediate action. If you answered letter D, patient with a phosphorus level of 4.5 milligrams per DL and calcium phosphate deposits in the soft tissues. This is a chronic issue. Calcium phosphate deposits in the soft tissues. Remember that our normal range for the phosphorus is somewhere between 2.5 to 4.5 milligrams per DL. So it doesn't require immediate attention, not life-threatening compared to our patient who has a magnesium of 1.1 milliequivalents per liter. Normally, our magnesium range is what? About 1.6 or 1.7 milliequivalents to about 2.5 milliequivalents per liter. This is critically low. Your patient has heightened reflexes, hypomagnesemia. Yeah, hypomagnesemia, they are experiencing tremors. They are lacking the magnesium, which is a muscle relaxant, supposedly. In this scenario, your patient has neuromuscular irritability. Neuromuscular irritability. At this point, they are prone to developing seizures. This is a safety issue. Very low magnesium level. Thank you, virtuous lady. Yeah, that is acceptable range as well. Your patient here can be at a higher risk to developing seizures. A safety issue. You need to correct this immediately. Heightened reflexes. So that is our correct answer, guys. That is letter C. So look for those options that are life-threatening, right? That can lead to life-threatening conditions. Anything that can affect brain function, neurofunction, anything that can affect their airway, especially hypocalcemia, those kinds of options that you should look for, okay? Or any of those options that can predispose them to developing ventricular tachycardias or life-threatening dysrhythmias. Those are the things that you should look for, okay? Even though they're not in these choices, but if you're going to be asked, especially in fluids, electrolytes type of question, look for those. Some things that can affect their circulation, cardiac dysrhythmias, something that can impair their airway or will compromise their airway, such as in laryngeal spasm in a case of severe hypocalcemia, or let's say severely low sodium or severely high sodium. Either ends, extreme sodium levels can impair brain function that can lead to seizures, that can lead to coma. So take note of those clues. Let's have number 13. All right. Which statement by a patient with SIADH indicates a need for further teaching? A, I should buy low sodium foods and avoid adding salt to my meals. B, I weigh myself daily and report sudden weight changes. C, I need to limit my fluids to 1 quart per day. And letter D, I should eat potassium. Statement that indicates need for further teaching. Statement that reflects misunderstanding. So pick that option. Your patient has a case of syndrome of inappropriate antidiuretic hormone. If you had answered letter D, I should eat potassium-rich foods because diuretics can lower potassium. I should eat potassium-rich foods because diuretics can lower potassium. Is this significant? Especially, guys, when your patient has SIADH, they have overload, fluid volume overload. So you are going to eliminate those options that are appropriate this time. You are going to eliminate the nursing actions or choices that are appropriate. What we're looking for in this, actually, statements from the patient rather. You're going to eliminate those statements from the patient that reflects understanding about their treatment. They have SIADH. So if you answered letter D, the patient will have fluid volume overload. And at this point, we need to get rid of the extra fluid circulating, right? And they are expected to be given the diuretics to get rid of the extra fluids. And what's going to happen if they're going to be getting the diuretics? They will end up with low potassium, hypokalemia. And so if they stated, I should eat potassium-rich foods because diuretics can lower potassium, yeah, it reflects understanding. But this is not what we are looking for. They are understanding that they will be getting the diuretics. They will end up with hypokalemia, and so they're going to take high potassium in their, they should be taking high potassium content in their diet. So this is reflecting understanding. If you answered letter C, I need to limit my fluids to 1 quart per day. Yes, that is also a good statement because they already have fluid volume overload. You don't want them to dilute further their sodium level. And so this is reflecting understanding that they should limit, they should restrict their intake of fluids. If they stated, I'll weigh myself daily and report sudden weight changes, that is reflecting understanding. Especially that when we are treating them with diuretics, restriction, fluid intake, yes, this is reflecting understanding as well. So we are eliminating that one. But why letter A? I should buy low sodium foods. No, they should not be doing this because they will be needing more sodium this time. Okay. The patient will have the hyponatremia in this case. They will require sodium supplementation, not restriction. Okay. Requires sodium replacement and supplementation. I'll just abbreviate that one. So that is letter A. This is a statement from the patient that requires more education. We are going to prevent delusional hyponatremia in a case of SIADH. What we want to prevent here is to cause a decrease in their sodium level. We need to restore that level in 135 to 145 range. Let's have number 14. A patient with primary hyperparathyroidism shows low phosphorus and high calcium levels. What should the nurse include in their care plan? Is it A, keep the patient on bed rest, B, encourage drinking 4,000 mLs of fluids daily, or C, implement routine seizure precautions, or D, check for positive Vostek sign? Patient with hyperparathyroidism, primary, shows low phosphorus and high calcium levels. What you should do here as a nurse formulating their care plan. Will that be A? If you answered the letter A this time, keep the patient on bed rest. Take note that your patient has hypercalcemia greater than 10.5 milligrams per DL, right? If you're going to allow them to be on bed rest, if you're going to implement them on bed rest, this is going to worsen their hypercalcemia. Worsens hypercalcemia. Why? As we know that when there is less weight bearing in those bone structures, this can lead to the bone resorption. There will be shifting of the calcium ions from the bone tissues into the bloodstream. Again, if there is bed rest, if you are not allowing this patient to have weight bearing on their bones, this can promote bone resorption, the escape of the calcium ions from the bone tissues into the bloodstream. All right, so we are eliminating letter A. If you're going to select letter D, check for Vostek sign, this is only seen in a patient with hypocalcemia, not hypercalcemia, so letter D is irrelevant. Vostek sign, Trosu sign, tetany, twitching of the mouth, numbness around the mouth, those are signs of hypocalcemia, so it's irrelevant in this scenario. If you had answered letter C, implement routine seizure precautions. You think hypercalcemia can lead to the seizures? The seizure precautions is more appropriate for a hypocalcemic patient because of the neuromuscular excitability, but not in hypercalcemia. So again, this is more appropriate in a patient with hypocalcemia because of the neuromuscular irritability. What you can find in a patient with hypercalcemia is that they're going to end up with muscle weakness and lethargy. So it doesn't mean that when the patient has hypercalcemia that you're just going to allow them to walk around on their own. No, of course. They would need some assistance in order for them to maintain some physical activity, ambulating in the room with assistance because of their lethargy and the muscle weakness. They are at risk to falls. We don't want that happening into our patient. So we're not going to allow them to be on strict bed rest, but we're going to allow them some form of physical activity, maintain weight bearing on those bone structures. Okay? So if you had answered letter B, encourage drinking 4,000 mLs of fluids daily, the exact reasoning for that is to prevent calciuria or calcium stones. This will flush their urinary system by preventing, we are preventing the formation of calcium stones by increasing their fluid intake, preventing calcium stones. Okay? Minimum amount of fluid intake per day in a case of hypercalcemia. So don't forget about this, guys. Letter B. So if you're going to ask, what are the other treatments involved in a case of hypercalcemia? Aside from increasing oral intake, one would be the normal saline infusion in order to make sure to flush those calcium stones out of their system. And another is the administration of furosemide. This will decrease the calcium level in their bloodstream. This will allow excretion of the calcium. So take note of that. And we will talk more about these when we get into that imbalance in the endocrine system, which we will be talking in the next few days. Let's have number 15, our last item of the day. A dialysis patient is unresponsive and has decreased reflexes after taking an antacid containing aluminum and magnesium. What should the nurse do first? Is it A, contact the healthcare provider immediately? B, get an order to check the potassium level? C, look at the patient's last magnesium level? And D, educate the patient about avoiding magnesium antacids. A dialysis patient is unresponsive, has decreased reflexes after taking an antacid containing aluminum and magnesium. What you should do here as the RN. Will you do letter A, letter B, letter C, or D? If you picked letter D, educate the patient about avoiding magnesium antacids. This is appropriate, but it is appropriate when the patient has regained consciousness or after you have dealt with the issue, right? The education will follow after you have already treated this patient and when the patient has regained consciousness. But this is not the immediate priority in this situation. Education is important, but not applicable in this acute phase, not the priority nursing action in this time frame. Okay? Not immediate action. If you're going to answer letter C, look at the patient's last magnesium level. We know that the patient is taking the aluminum and magnesium antacids already, and it has caused them to be unresponsive. So we know that reviewing their magnesium is very useful, but again, that will not provide immediate resolution to the acute symptoms. What we need to do here is to address the suspected hypermagnesemia. We need to notify the medical provider because we already have a clue regarding the aluminum and magnesium intake. If you're going to contact the medical provider, this is going to hit two birds with just one stone. You are notifying about the patient's unresponsiveness and decreased reflexes, and notifying them about their recent intake of the aluminum and magnesium type of antacid, right? So when you get in touch with a medical provider, you can get a lot of stuff from them this time. Probably they're going to order a much more, they can order a basic, not basic, but chemistry panel to really identify their electrolyte levels, right? Okay. Letter B, check the potassium level. It is not really relevant into this scenario, as we know that the potassium level is not going to be influenced by the aluminum and magnesium antacid. It doesn't really cause this unresponsiveness and decreased reflexes. So there is no known relationship between the potassium and the other electrolytes involved in this case. The patient is known to be with acute renal failure. They are doing the dialysis. And the issues more occurring in this scenario is about the retention of the magnesium and also the aluminum, which will lead to that manifestation. So again, take note about letter A. Contacting the healthcare provider will be the crucial step. This is going to let them know immediately so that they can order those necessary interventions to prevent further complications, right? We need to treat that first by letting them know about the value, about the manifestation. Rosalie Maxime, is 4,000 mLs daily not too much? Well, it can be too much for those people that may have pre-existing conditions, let's say heart failure. Yeah, but with the limitation of the scenario that we have in number 14, we don't have any additional information that they have such comorbidities. And so the general care for this patient with the hypercalcemia is to increase their intake. 4,000 mLs daily. It doesn't mean that you're going to give this in 1 hour or let's say 6 hours. It has to be given during the 24-hour period. Okay? Yeah, don't think about administering the fluids within just a short time. It has to be distributed throughout the day, not instantaneously. This can cause a rapid fluid volume overload in your patient. So yeah, take note about that. So that's the end of our exercises today. We will be tackling endocrine disorders tomorrow. So I believe that we'll be starting with the critical nursing actions in the management of diabetes, both type 1 and 2. So thank you again for your participation today, and I hope that you are learning as we are going along the the phases of the review. And I hope to see you again tomorrow. So you all take care and goodbye for now. I'll see you tomorrow at 9 p.m. Eastern Standard Time. And please don't forget to sign up in our NCLEX course at www.stancoast.nclexcoaching.com. And please click the link below. And don't forget to hit the like button in this video, and also don't forget to subscribe, and don't forget to share this video to your friends who are also preparing for the NCLEX. Again, bye and see you tomorrow.